So I want to talk to you about what I do. I'm a breast surgeon, but I'm also a minimally invasive general surgeon. And I have great colleagues to work with, like Dr. Bushi and Dr. Kabak. And so tonight I just thought I'd talk to you about a couple things that are near and dear to my heart. Breast cancer for sure is one that occupies a great deal of my time. I'm happy to see many of my patients out here today. But one of the things that we've been able to do at Scripps in the last year is to bring intraoperative radiotherapy to our patients. And I've gotten to be a part of that more recently. So I wanted to talk about that. The other thing I wanted to talk about is how genetics and risk indices that are coming out are helping us treat our patients and decide who gets what treatment, who's really going to benefit, and who we should put through and risk the side effects. The second thing I wanted to talk about is what Dr. Bushi talked about, which is minimally invasive surgery done with the Da Vinci robot. I've been a laparoscopic surgeon for most of my career as a surgeon, and it wasn't until about 2010 that I realized that there was really a place for robotics in my practice. And it's something that I think is awesome. So I'm going to spend a little time telling you about that. But the first thing is the topic of breast cancer. And we all know how many friends and family and that are affected by breast cancer. And for many women, for a lot of women, we can offer breast conserving therapy. And that means that we can do a lumpectomy and then follow that treatment with radiation. Radiation has many forms, and we've tried partial breast radiation in several different forms over my time at Scripps, and most of them have kind of fallen out of favor. I remember the first time I did a brachytherapy with Dr. Koch, I said, that is barbaric, I'm never doing that again. And thankfully, we've advanced and we really take on new therapies as they come available. And I think we push the envelope for sure. And it's because of some philanthropic efforts that we actually have the Mobitron at Scripps and can offer partial breast radiation during a woman's surgery. Right after she gets the lumpectomy, we're able to give radiation.
While the boost can be offered to any woman who's a good candidate for breast conserving therapy, the single fraction, which is what we're pushing for, is really a specialized treatment that we save for the women who have probably the more favorable cancer situation. So right now we're working on putting through a protocol. Because this is early in the development, we can't do this without doing a research protocol. So we've got to follow all the patients that we offer this to and that we do perform it on. So we're hoping that that's going to come forward soon and that we'll be able to be doing that one and done surgery, radiation, and you're out the door to get on with the rest of your life. Just a little piece about radiation treatment in general. It's totally different than chemotherapy. Radiation, chemotherapy, surgery, those are the three things that we do to take care of patients with breast cancer. But radiation really decreases the risk of a local recurrence. So whether you've had a mastectomy and you're getting post-mastectomy radiation, or whether we're saving your breast, the radiation is what decreases the risk of the tumor coming back. It turns out that it decreases it by at least 50%. And so for women who say, no, I'm not getting that radiation, they've got a 35% chance or greater of having that tumor come back. And believe me, I've seen it. I've had patients say, nope, I'm going to Mexico. Nope, I just can't do that to my body. And unfortunately, it does come back. And then we sometimes have a more difficult situation to deal with. But for the women who go ahead and have that radiation, we can really control the disease well. It also decreases your risk of death a considerable amount, from 25%, say, to 21%. And for every 4 patients who will have a recurrence, we can prevent 1 death. We can also see a big difference. We can divide that into patients, we worry about spread of lymph nodes or spread of cancer to lymph nodes. And so For the patients who don't have spread or node negative, their risk reduction is 50% at 10 years. Those that have node positive, their risk is still reduced, not quite as measurable. It's reduced by about a third. When we were looking at this intraoperative radiotherapy, there was a target trial involving like 3,400 women. And so they compared those that got the intraoperative radiotherapy, which really only radiates part of the breast, doesn't radiate the whole breast. So because of that, we think there's less side effects. Certainly we spare the skin, but we actually protect the chest wall. And so that beam of radiation really just radiates the breast tissue around it that we want to hit, and not the chest wall and the ribs underneath. So hopefully we'll have fewer side effects. In the trial, they looked at women over 45. They specified that it must be only one tumor, not multifocal. And they saw basically the same rates of local recurrence. I should be cautious in that. The trial actually showed that there was an increased risk of local recurrence, but it's a very small number. It is statistically significant. But if you look at it and you said, well, the women who had whole breast radiation had a 1.3% chance of a local recurrence, and the women who had the localized intraoperative radiotherapy had a risk of 3.3%, would you not do it? For me, I would probably go do it for that number. I think that's a small number. It is statistically significant, but when you look at some of the other upsides of that treatment, and the fact that most women who would be offered this treatment are going to be estrogen receptor positive, so that the tumor is sensitive to estrogens, they're also going to get additional treatment, which helps to reduce those risks. It's something that I would certainly consider as a patient. So I think it's a wonderful thing that we can offer this to our patients and hopefully get more and more data that's going to support continued use of this treatment. Did I mention fewer skin complications? I think I did. There was another trial where they just simply looked at any woman who was going to be considered for breast-conserving therapy, and basically they had similar results. But what fell out was that the women who have a higher risk cancer, meaning a bigger tumor, nodes that were involved, a grade 3 tumor, so a tumor that we would consider higher risk, those patients weren't going to do as well, and their risk of recurrence was much higher. So the take-home lesson from that study was we really shouldn't be offering this treatment to patients who are at higher risk. And so it helps us to keep our inclusion criteria fairly tight. So the next thing that some of you probably heard about, I know many of you, there's some patients out there, but there's a study that looks at who really benefits from chemotherapy. And when we look at breast cancer, one of the most important things we look at is the estrogen receptors and whether they're positive or negative. And so the Oncotype DX is a biochemical or genetic test actually done on the tumor itself that's removed and stored in pathology. But what it looks at is what's your risk of recurrence? What's your recurrence score? And all the little nuances of your tumor. Can we predict whether or not you'll do fine with hormone therapy or should you have chemotherapy? And so this is a test that's applicable to premenopausal women who are still menstruating, who can only take tamoxifen. But it used to be that we only offered chemotherapy to, or premenopausal node-negative women, they would all get chemotherapy. And because of the Oncotype DX, we really look more closely at what's going on with our patients and are they really going to benefit the potential side effects from the chemotherapy. And so I think that's really changed how we take care of our patients. And I think it allows us to really look at who we're treating, are they benefiting, and should we do that. All of the patients who have that test, that number that you get assumes that you're going to be good and take your estrogen modifying treatment, either tamoxifen or Arimidex. We basically block estrogen either at the site or we block the conversion of estrogen in our bodies. And so that number assumes that you're going to take the anti-estrogen medication that your doctor probably is going to prescribe. There's a new test actually that has just come to my attention. It's called the Breast Cancer Index. And it's a test that actually looks at what do we do after 5 years. Everybody's looking to that 5-year, I'm cured, I get to stop my tamoxifen. But there was some newer data that showed that maybe we should continue those medicines past 5 years. One of the things we see once we're in practice for 17 years is that some of our patients actually get recurrences late. 12 years, 16 years. I just had one at 17 years. And it's pretty devastating. And so the question is, how can we predict who those patients are going to be? And what can we do differently to maybe prevent that recurrence from happening? And so the Breast Cancer Index, which is by a company, actually, I think it's local here in California, called Biotheranostics, predicts the late recurrence after 5 years and helps to decide who should continue with the hormone therapy. For those of you who were there, who've taken tamoxifen or Arimidex and all these medicines, you know that it's not a pleasant time. It's like going through menopause again if you missed it the first time. And so everybody's quite anxious to be off of the medicine. Nobody wants to hear from their doctor that, oh, you should take that for another 5 years. And so this new test, I think we have to consider it carefully because of the benefits of blocking those hormones. If it means the difference between you getting a recurrence and you know that it's based on good data, it'd be pretty compelling to consider toughing it up and taking the medicine rather than not. But if you're one of those patients where it's not going to help, then why suffer the consequences? So I think that that's really an important part of our future, that we're getting much, much better at looking at which patients are really going to benefit from the therapy that we're recommending. And so I'm looking forward to see how that helps us in the future. So that brings me to robotics.